difficulties with your memory. Cognitive deficits in epilepsy. As a broad group, in general sense, people with epilepsy tend to have impaired cognition, impaired IQ. However, there's a lot of variability, and many patients have normal intelligence or superior intelligence. Epilepsy affects people of all different types. So we look at the causes of the seizures, the age of onset, how frequently they're having seizures and how severe they are, and what medications they're on. Again, medications like phenobarbital, dilantin may have a greater effect on cognition. The newer medications, we think less so, but probably they too have some effect on cognition and memory, depending on how carefully you test for that. Emotional and behavioral. As we all know, epilepsy is a chronic disorder, and it's unpredictable. It's frightening, and it's poorly understood by the general public. A lot of stigma, a lot of misperception. It disrupts the dynamics of the family. Parents might feel guilty. They may overprotect their child. Siblings may be jealous, and the patient may feel rejected. So a lot of stuff that goes on with epilepsy besides just the seizures. Psychiatric disorders are also much more common. Anxiety, depression, hyperactivity, aggression, suicide. It's sad, but there's a higher incidence. The medications we use may affect the mood, some of them in a positive manner and some of them on a negative manner. Many of the anticonvulsants are used by a psychiatrist for mood control. Lamictal, Depakote, carbamazepine, trileptal have some mood stabilization properties. Others, like phenobarbital, Keppra is well known for activating, perhaps inducing some mood changes. And finally, kind of the social issues of epilepsy. Again, there's a stigma with epilepsy. It's not understood well by the public. There's concern for participation in sports and social activities. Parents may be reluctant to let the child go out to the prom, go out with their friends, or participate in sports, and that impacts their social development. Poor self-esteem, negative self-image, embarrassment, big issues. Feeling isolated, feeling different, can't do sleepovers. Sleepovers are a big deal when you're 10 years old. Summer camp, something we all did when we were little. It's very hard if your child has epilepsy. I'll come back to that in a second. And adults, marriage, driving, employment, insurance, all a problem. This is just kind of my final slide. The chef knows this well, but there's a camp in town, near Orlando called Boggy Creek, where children with epilepsy can go spend a week and be a normal kid, stay up late, have campfires, ride horses, and this is a great event. The EFA sponsors this every year, and patients go free of charge. So if your child has epilepsy, this is a great thing to take advantage of and talk to your doctors about. And this is kind of my final slide, emphasizing that we need to increase the awareness of epilepsy. It's a condition, it's not a disease, and most people with epilepsy lead normal lives. And I'll stop there and let the next speaker come up. Oh, just FYI, there are apps now for everything. So this is an app from the Epilepsy Society about how to keep a diary of your seizures. Many patients will write them down on a piece of paper, but now if you have a smartphone, you can do everything on an app. Same with migraines. So you use technology a little bit too. So thank you.
Thanks, Harry. That was a terrific talk. The next speaker is a personal friend of mine. He is Dr. Raj Sheth. He is the chief of pediatric neurology at the Nemours Children's Hospital and has an appointment at the professor level at the Mayo Clinic College of Medicine. And he's going to be speaking to us about healthcare decision-making in childhood and adolescent epilepsy as we move in our transition from childhood through to the adulthood. Dr. Raj Sheth.
Thank you, folks. What I was just getting ready to do is put $20 in that gift bag to give that book away. But thank you for pretending to have won it there. So Dr. Abram gave you an absolutely outstanding overview of epilepsy. And what I will do is actually have one foot in each camp, the pediatric and the adult camp. And really, you can't talk about this condition without talking about it as a spectrum type of problem. And what I'd like to do is actually give you some of the non-discussed issues in epilepsy that we talk about. We always talk about certain aspects of it, but really to give it the blood and soul of the whole thing. So that's what the focus of this talk will be. And with that, the key issues and decisions are what you've just heard, but just to reiterate them, is the key decisions are on the steps to seizure freedom, because that's where it's at. And you want the right diagnosis, the right classification. Dr. Abram really talked very nicely about how that's classified. You want the right treatment plan. He talked about an acute seizure plan. What's the plan for your child? And that deals with education, the rescue that he talked about very correctly, and the right AED. But with that, what I thought I'd do is show you some seizures, and let me just expand this a little. And not that this audience needs to be educated about what happens during seizures, but I just wanted to give you a sense of the spectrum of the whole thing. And here's a boy from our clinic in Nemours that is, excuse me folks, I know that link didn't work, but here it is. So what's happening here, he's doing your typical hyperventilation, and as he blows, you will see that he suddenly has an arrest, and then he has somewhat orobuccal automatisms, and then he's back to himself. So he's blowing over there, and I'm sure lots of y'all have had examples of blowing on the EEG, and then you'll see suddenly, at some point in time here, he'll have an arrest, and then I know if I speed the video up, I'm going to miss the whole thing, so be patient with me here. Okay, here it goes. So he is having a absence seizure, and the reason we know it's absence is because it actually, you can see the EEG shows a 3 Hertz spike and wave discharge. He has more prominent orobuccal automatisms than you typically see. And you can see that he's chewing his lips quite a bit, and then he's back to himself. So the absence seizures, and also called petit mal seizures, and I always, the word petit mal makes me think I'm in a lingerie department between grand mal and petit mal and all these French terms that you've got going. But it's an absence of spirit, an absence, and then you come back to yourself and you're completely normal. So that's one end of the spectrum. And here's the other end. This is a patient that I saw as a 16-year-old. She's about 23 years old now, and you can see when she came to the emergency room with this, the feeling was that the ER doc thought that these were really psychological types of events. And she is an absolutely delightful patient over here, and the tech is doing exactly what we tell them not to do, which is cover a patient up when the video is going on. But those are the movements that occurred. And you can see that they're very fragmented, very sporadic, and as you go along, they tend to get a little bit further up the arm. And for some reason, these happen more on the left side than the right side. And she was a little bit embarrassed about this, and as we move along here, let me just sort of move this thing onto. What she then did was very interesting. She pulled her right hand out to try and prevent the left hand from doing the jerks. And as you can see that the jerks were ongoing. And you can imagine why an emergency room doc who's not fully aware of epilepsy would think, boy, these look psychological. They don't, pseudo seizures, they don't look like epileptic seizures. And You can see they're somewhat more prominent here. And this goes on for quite a bit. And her father, actually, when I talked to him, said he was a fisherman, and he said that she looked like a walleye out of water. She would flop around and jerk around. And I'm going to speed this up so we, in the interest of time, and you can see she's fully conscious, fully aware of what's going on. And here my new fellow, Justin Stahl, he's in Washington, Seattle actually now, came in here and was absolutely convinced these were psychological events, and he was trying to hold the wrist to prevent the seizures from happening, and you could see that they were clearly there, and that was the right thing to do. And watch what happens now. And she has what is a generalized tonic-clonic seizure. You see a stiffening of the extremities, an extension that Dr. Abram talked about with the spine, and then you have, that's the tonic phase, and it's gradually transitioning into the clonic phase. So what started off, and you could see in the early part of the video, she was smiling about this, really it reflects the seriousness of this condition. And I really don't need to tell this audience anything about the seriousness of the condition. So you've got a spectrum from what you first saw in the first patient, which was very mild, at least to the naked eye, and then where you had this sort of a tonic-clonic seizure that's very dramatic and very severe and has lots of consequences with it. Now, what we'll do is talk a little bit about the areas suggesting it. All the focus is always on the seizures, as it should be, but there are a whole bunch of things we don't think about, and that has to do with medication side effects, and they can be pretty awful. School, big issue. Driving, a huge issue. Work, family, and children, and so and not least of which are parents, siblings, and caretakers. Oftentimes we focus on the parents or the caretakers, but we don't focus in on the other children. When you have a child with chronic illness, the other children oftentimes either are neglected just because so much of attention is needed on one, and I can see families here with lots of siblings, I presume, who really form a supportive network, and the idea is to get them involved in the same sort of thing. So that's another very big issue. Now, when a patient comes to see you, and I always make a point of talking to the patient, because I think oftentimes, especially with children, you tend to talk to the family and you don't tend to talk to the child as much. And there are lots of little gems that the child can tell you, something about the seizure, but also very often about what their feeling is. You get a sense of what their fears are. And that's missed if you just talk to the parents and avoid and don't talk directly to the children. Do I need to be on an AED? These are the expressed fears. Can I drive? Parental concerns, especially with a son, dependent and dependent daughter. Unexpressed fears in my adult patients would be financial independence. Can I work? And will I ever be normal? Will I love and marry? Will I give my child epilepsy? These are huge issues. And I can't tell you the number of times I've seen such terrible guilt that comes through with, I must have done something wrong in the pregnancy for this to have happened. And that's a huge burden that to bear. Will I ever be independent? That's another very big issue. So what we're talking about really is transitions from the pediatric age to which Dr. Abram talked about, to where Dr. Tatum talks about the adult age. And transitions are easy to talk about, but so difficult to do. And let me tell you that when a person is pregnant, when a family is pregnant, they don't really think of that child as a little blob of fat and lovely, cuddly smiles and things of that. They're sort of imagining this child off to college, and off married, and up as a teenager. And suddenly when you have epilepsy strike in this young age, suddenly there are lots of fears that come up. Will my child ever be normal? I mean, I was thinking about this. We don't tend to think of a child just as a 1-month-old. We tend to see the whole spectrum in one shot. And so it's very damaging to the psyche. And I can tell you that this is my daughter, who does not have epilepsy, but transitions, I can tell you, are pretty scary regardless. Here she is with 5 with M&Ms on ice cream. And there she is, all on her own in China. This is the Great Wall of China. This was a school trip, and she spent a month there. She speaks Mandarin, of all things. I can barely speak any other language other than English, and here she is with Mandarin. So that's a transition. And of course, the reason why I have no hair is because of this other transition that takes place. And this is winter formal. So really, when you talk about this in a normal situation, there are already anxieties related to growth and development, to independence. Are they going to be okay? Are they going to be good people? Are they going to be happy? And when you add in that, this horrible cloud of epilepsy, it really adds the magnitude of the problem just increases. I had a patient once who was 27 years old who told me that if he had to add up all the seizures that I had in a year, it would probably be less than 10 minutes. And yet every single day it affects my life. And that's the wickedness with this condition almost. It just is there. You never know when it's going to strike. It's not something predictable. It's not like your diabetes where you ate a little bit extra, you didn't take your insulin, and your sugar is low, and you know why it is. This is for no reason it happens. So it's very, very bothersome. Dr. Abram talked about the fact that a lot of children have benign epilepsies, quote-unquote benign epilepsies of childhood. They outgrow it. The only exception for these benign epilepsies is the girl I showed you. She had juvenile myoclonic epilepsy, and what you were seeing on the video was myoclonic jerks. And anytime you have a patient that has an epilepsy, anytime you have a young adult that comes to the emergency room with a first-time seizure, and they're otherwise completely normal, chances are 25% of them will have juvenile myoclonic epilepsy. This is a condition that oftentimes is not recognized for what it is. And once you recognize it, you know the treatment that is most effective, and this always stays controlled with medication. So it's an important thing to recognize. There was a study, and this is out of Sweden, where apparently, just like Olmsted County and Mayo, Rochester, where they follow people for 30 years, in the U.S., when 20% of us are moving every year, or every 5 years, it makes it difficult to do this. But this is a follow-up of 245 children with epilepsy and follow them for 35 years. And obviously, these were not the benign epilepsies. And they found that education levels were lower, employment rates were lower, marital status was lower, physical fitness was lower, and psychiatric comorbidity was higher. And it's not surprising. It's not surprising. Where do seizures come from? They come from the brain. Where do psychiatric problems come from? They come from the brain. It's not surprising that there may be an interaction between the two. And I think the issue here is not to feel low about it, but to really recognize it. When a patient is telling you that their mood is changed, to really take that into consideration when you're talking about a treatment plan and talking about treatment issues for this. And across the spectrum, across the life spectrum, as we transition from the baby up to the 65-year-old, you can see that the causes of epilepsy are very different. If you talk about a child with epilepsy, the first thing a family member thinks of, the first thing a medical student resident thinks of, a pediatrician thinks of, is, oh my God, a brain tumor. Brain tumors are very rare in children to cause seizures. Very rare. Not that it doesn't happen, but it's very rare. Now, if you take an adult, 65 years and older, stroke is going to be the common cause for epilepsy. The commonest cause for new onset epilepsy is stroke. And you can imagine why that is. Brain tumors, another common cause over here as you get older into that 24 to 45 age group. And you can see the bar in 0 to 4 doesn't even exist. The blue bar with brain tumors doesn't even exist. In 5 to 14, it's a small percentage compared to everything else. So there really is a transition in terms of this is not one disease. And you can recognize it right throughout. This has different causes, different manifestations, and a lot of different aspects related to this. Now, Dr. Abram talked about two types of seizures. We're again talking about transition. If you talk about the underage 1-month-old, all seizures are focal seizures or partial seizures. Again, this terminology is very confusing, and we have the French to blame for all this. Because I had a patient ask me once, what do you mean I have partial seizures? Do I have seizures or don't I have seizures? It's like pregnancy. Am I pregnant or am I not? And so very difficult. And I think the word focal is probably much more accurate in terms of our culture and our context. Look at what happens between 1 month and 2 years. 50% of epilepsy is focal, 50% is generalized. This is the bad age to start having seizures in. Usually the conditions that cause it are quite malignant, infantile spasms, and all the things that does to a person. 2 to 10 years, there's actually more generalized seizures than focal seizures. And the generalized seizures are oftentimes absence, juvenile myoclonic, a lot of benign conditions come up in that age group. So very, very optimistic in terms of control of seizures. 10 to 18, that's another thing where they're transitioning, and then by the time you get to 60, all the seizures are focal. I mean, there are very few seizures that are truly generalized seizures. And this is why when families talk to each other, there's such a different experience depending on which age you're at, and it's very difficult. If you talk about cystic fibrosis, there's a commonality to it. When you talk about epilepsy, it's very disparate, and it's because of these various aspects that underlie the two different types. Now, I'll talk a little bit differently than Dr. Abram did about medications, and just to show you, these are the medications that were up to the 80s. And if you look, I'll skip those slides for a second, but if you look at it, in 1985, the VA did a wonderful, wonderful study, very carefully done, and said, if you start one medication, what's your chance of becoming seizure-free? 50%. If you go to a second medication, you change that, take that medication off, you put a second one on, it's 10%. And if you add 2 medications together, 3% become seizure-free. So some of you all who are on multiple medications and feel that frustration, this is the reason why you feel that frustration. Because once you get beyond 2 medications, the chances of medication controlling seizures goes down. It's not 0, but it goes down significantly. So another aspect, the total controlled are about 2/3, and not controlled is 33%. So just remember that number, 1/3 not controlled. Now, how have we done? Dr. Abrams got an elaborate slide showing you all the new medications we have in the recent times, and look at the numbers over here. Let me just get to the bottom line. With all these new medications, the seizure control rate hasn't changed. So what that tells us is there's something about the biology of a certain percentage of epilepsy, a large percentage, 33%, that make them intractable to the common medications that we talk about. It's something about the biology. Remember that seizures is not a cell problem, it's a network problem. If you're in this room, if you took a picture of the walls of the room, which would be an MRI scan, the walls can all be up. The room can look intact. And yet, the electricity in that wall may not be right. So if you have a hole in the wall, or you have a lesion on the MRI scan, the electricity is going to be wrong in that wall, and the seizures are going to take place from that. But you can have a room that looks totally intact, meaning the MRI scan is normal, and yet the electricity is abnormal. This is a network problem, and there's something about the network, once it gets established, that sets it on that pathway to intractability. This is why surgery, for instance, can disrupt the network, depending on where that critical area is and in the right patient, and can sometimes help with that. So really, the main points are, from an efficacy point of view, all of these last 30 years have been for naught. The old medications and the new medications, there's no difference in efficacy. What's has changed? The big change is really in the side effect profile. When you look at the older medications with the side effect profile from phenobarbital and Dilantin, you compare it to the others, it's night and day. So the adverse effect profile is improved, but the efficacy rates, the core element hasn't changed. That's the frustration, that's the challenge with this disorder. Now, here is a patient of mine that had a lesion in the temporal lobe. This is an MRI scan. This side looks completely normal. That's the brainstem right there, a little bit of the cerebellum that you can see, the eyeballs up front, and right over here is a large lesion in that temporal lobe. Now what we did was, at Nemours and Wolfson Children's Hospital, we did what's called tractography. This is a hugely improved technique to say which way are the tracks going, which way are the fibers that connect up various areas going. And you can see beautifully over here, these are actually, and this is all in the last 5 years that we've been able to do this. You can actually map the tracks that connect various areas of brain together. Another phenomenal development. That's what it should look like normally. All these fibers going back and forth. Here's the optic nerves. Those are the optic nerves coming in, the commisure connecting the two sides of the brain. Look at this side over here. The fibers are actually splayed open. So that was very helpful in our surgical decision planning. And here is, I apologize if there's anybody that this would be too difficult to look at, please avert your eyes, or I can, if you'd rather I skip over it, I can skip over it. But what we did was we basically approached the lesion with a grid to map the area of where the seizures are coming from. Because when you look at this tissue here, you've got a large area. Is this the area that, certainly it's not coming from this area here. That's the lesion. That's just a ganglioglioma. That's just a fluid-filled thing. That's not where the seizures are coming from. But are they coming from here? Are they coming from here? And epilepsy surgery does not only mean going after X marks the spot with where the lesion is, but actually mapping the area from an electrical point of view to get successful control of this lesion. So that's what we did in that scar. This is the patient. I have the permission of families to show this. She's 3 days out after surgery at Wilson Children's Hospital. This is probably 2 months ago. She was having 10 to 20 seizures a week. This was an entirely normal child who really had memory difficulties. Lisa Cox, our neuropsychologist, is going to talk about this. With seizures that are ongoing, sometimes memory is affected. And this is 3 days out. Dr. Aldana did a beautiful scar here, all of the hair's grown back. And the first question she came to see me 2 weeks after surgery was, when can I go back to playing soccer? So just a lovely thing. She's actually completely cured. She will remain on medication for a considerable period of time, 2 years, and then we'll gradually wean it off. So in this patient, we tried medications for 2 years, where she was having 10 seizures a week, 15 seizures a week, and without success. And you can see why, in a very gross level, why it would not be likely that the medications would take care of things. And again, if I told the family that the seizures are being caused by a brain tumor, or if I told anybody you have a brain tumor, you would say, of course we need to get it out. But when you talk about epilepsy, there's this certain reluctance to approach this area. I do not think that willy-nilly epilepsy surgery is the right thing, but I think oftentimes it's neglected as an option. The physicians are a little bit hesitant to talk about it. The patient thinks, why mess with it? And it goes on. So the average time from when the patient has epilepsy that's intractable to where they have surgery is 25 years. 25 years of all this difficulty. Now this child here has only had a year and a half of surgery and seizures, and she is a delightful child over there. We talk a little bit I want to talk about the fact that we've come a long way. This is a patient of mine that was on Dilantin. He's 24 years old, and you can see the effects of chronic Dilantin therapy, lots of gum hypertrophy and things like that. But this is what you don't see. Dilantin, phenobarbital can reduce your bone strength. And when you fall with a seizure, those bones that are weakened are more likely to fracture. And so there are hidden side effects that you don't really see. And so I think it's very important to talk about the whole patient. If a visit goes, how are your seizures doing? Here's your prescription. We'll see you back in 6 months. You need to stop and say, wait a minute. What are my questions? Write them down and talk about it in the clinic with yourselves. When patients with epilepsy tend to be their worst advocates. If you have a patient with a pain disorder, they're telling you about all the complaints plus 10 more. And when you have a patient with epilepsy, they just say, they somehow tend to quarter everything down and tell you they just had a seizure and that was it. But when you actually see what it all involves, it's a lot more. So sometimes I tend to think that patients with epilepsy are their own worst advocates. They don't tend to be as vocal about it. And certainly family members, please encourage that with it. Safer medications. This is a child that was put on carbamazepine and developed Stevens-Johnson syndrome. A terrible, terrible condition. She's survived and she's doing very well now, but really things we need to think about. Some of the newer medications, this is not an option. So sometimes when there's frustration that we haven't actually addressed the problem with seizure control, it's good to also remember what the old days were and where these medications came from. But seizure control is it. This is a 46-year-old patient of mine who was a carpenter working with a circular saw, had a seizure, and amputated a couple of his fingers here with this. So it is a terrible situation, a very, very difficult situation. There's still a ways to go. Here's a patient of mine, if you want to take a look and see which one do you think the, let's have a show of hands. Who do you think the patient is? The woman or the man? How many for the man? Let's say, okay, and how many for the women? Okay. So actually, let's look at this a little bit more. So that's her. What had happened was they were driving back from Chicago, and I'll tell you the details in a second, but that's his injuries there. And actually, the patient is the man. He did a very masculine thing, which is obviously filled with his medications. I don't know what it is about the XY gene, but we tend to do that. We don't ask for directions, and we tend to be more confident about tapering our medications when we did. And here he was having cognitive problems, and what he had learned to do was just cut his medications when he had an important meeting. And so he would then go to the meeting and be more clear. Instead of talking about it, instead of talking about the fact, is there other options, that's what he did. So really this can affect both people, and they're so lucky that this is all the injuries they had. So very, very, very important. Here's another patient of mine. This is a young lady that I saw at 16, diagnosed with juvenile myoclonic epilepsy, placed her on Depakote, which was that time the drug of choice for juvenile myoclonic epilepsy. Seizures completely gone. She's 24 years old, she's married, she wants to start a family, and she goes to the gynecologist. The gynecologist says, go talk to the neurologist. And so she comes to see me, and I didn't recognize her because she'd put on a lot of weight, and she had what's called polycystic ovary disease that may be related to Depakote. So really, some of these issues need to be thought of in the long spectrum of things, rather than just declaring victory with the seizures have gone, but actually look at these other aspects that are so can affect patients so much. When I have a young person who's talking about a family, here is a absolutely delightful child. The woman had epilepsy, was on medication. We got the right medication on board. We talked about folic acid in people who are pregnant. We talked about certain medications. Valproate, again, 12% of all patients who are on valproate when they're pregnant will have spina bifida, as Dr. Abram pointed out. So very important that you get those things planned. And when does that planning happen? Not when they're 25 and they're ready to start a family and driving, but really in the transition years before they start driving. So you're able to say you need to be on a medication long term. Is this the right one for you? That's the question to ask. And you can choose different medications that don't have this type of an effect, so that the family, the couple doesn't need to make this decision at 25 where you have to stop driving for 3 months while you switch medications. So certainly something that's important and you need to be aware of. And sometimes it's not so difficult. This is a 68-year-old patient of mine. I can't tell you her name, although I know her name just from a HIPAA point of view. As I said, I have permission from all these families to patients to show their pictures and things, and as in an instructive light. And this is a patient of mine who had absence epilepsy. What did Dr. Abram tell you what absence epilepsy? A benign epilepsy. However, about 5 to 7% of patients have intractable absence epilepsy, and she has intractable absence epilepsy all her life, despite multiple medications and things like that. So really, remember that every patient may not fit the book. They may not have read the book to know what symptoms they should be having or how their epilepsy should do. So keep an open mind, and that's more for the physician end, but also from the family members' mind. Now here I love to call these the Take Charge Sisters. Two of them are in engineering school, and one's headed to FSU. Very, very high functioning family. Where do you think the patient is? Who do you think the patient is? Which one? The middle one. Okay. So and you're right, she is the middle patient. She's the youngest child. I often tease this family that they treat her like Cinderella here, getting her to do housework and all this when she shouldn't be doing anything. But she's an absolutely delightful child, and that's her dad. Very, very high-functioning family. I remember when we had the patient in the hospital for monitoring, Mom, who's a teacher, math teacher, actually brought her all the homework to do, and I had to write an order saying no homework while in the hospital. So very, very high-functioning and challenging family. So in conclusion, let me wrap it up and say that the child is not static. You saw the transitions I talked about. It's a moving target and constantly evolving. So I think it's good to keep an open mind that things change, the types of decisions change. If you talk about a 7-year-old, the chance of medication non-compliance is virtually zero because the parent's making sure things happen. If you talk about a 15-year-old, the chance of medication non-compliance is massively high. I no longer ask them, do you miss a medication? I now ask them, how many times did you miss a medication? Because otherwise, they're going to tell you they never missed a medication. So really focus in on that. And I think if they get, I don't think many of them do it with a malicious intent. I think it's, although they're 15-year-olds, so I can't be absolutely sure about that. But if you have a simple strategy, buy your toothbrush. If they know to brush their teeth in the morning, they take the medication. Brush their teeth at the night, take the medication. So that's one aspect of it. Epilepsy is not static. It's a moving target too. So you've got, this is the reason why this disorder is so complex, because you've got growth and development and all those things happening. You've got the epilepsy changing too. Sometimes with more and more seizures, sometimes they become more intractable. There used to be an old concept of seizures beget seizures, which is why sometimes you tend to be more proactive about controlling seizures more effectively. And the treatment plan needs to be adaptive. It needs to respond to this through. But I have worked for 20 years with the Epilepsy Society, Epilepsy Community. I'm the secretary for the Epilepsy Foundation of America in the national organization, and this is a very resilient community. And this morning as I was driving, I don't know if you can see that picture as well. Maybe the light's a little bright. But really this is a tree, and here's an electric pole. And I think in many ways, I find the epilepsy community so adaptive, parents so uplifting, family members, patients, that if there's not a way through it, there's a way around it. And I thought this morning when I looked at this tree right outside my yard that I thought it really reflected some wonderful things about epilepsy. And with that, thank you for your attention. Appreciate it.